Good morning, everybody. We are going to go ahead and start the webinar. I am Molly Dino, the project coordinator for the California Evidence-Based Clearinghouse for Child Welfare, or CEBC for short. I'd like to thank you all for joining us and welcome you to the webinar. We've muted your phones due to the high number of participants attending, so if you're experiencing any technical difficulties or have any urgent questions, please use the chat pod located at the bottom of the screen and we will do our best to assist you. We will also have a brief Q&A section at the end of the webinar. Please use the chat pod to send us your questions. Please also find the PDFs of the webinar PowerPoint slides and other webinar relevant materials at the bottom of the screen in front of you. Lastly, you will receive an email after the conclusion of this webinar with a link to complete a short and easy survey so we can continue to improve our webinars and make them as useful and beneficial as possible in the future. So now I'm going to go ahead and turn it over to Jared Martin, who will give you all a quick introduction of the CEBC.
All right, hello everyone. So before we introduce our speaker, I did want to give a brief overview of the California Evidence-Based Clearinghouse for anyone who's not familiar. So we're going to go next slide. So really quickly, the CEBC is funded by the Office of Child Abuse Prevention, which is a part of the California Department of Social Services, and it's operated by Rady Children's Hospital in San Diego. And so we are a part of the Chadwick Center within Rady Children's Hospital, and in collaboration with the Child and Adolescent Services Research Center. And just really quickly, our mission here at the CEBC is to advance the effective implementation of evidence-based practices for children and families involved in the child welfare system. We accomplish this by two main goals. We have a program registry where we rate and review programs that could be applied to child welfare agencies or family serving agencies. And then we also have some resources and tools that providers can use to learn about how to effectively select and implement an evidence-based practice within their agency. Oh, there we go. And so I have a quick, I have a screen cap of our homepage of our website for those that haven't been to it. And if you haven't been to it in a while, we have an updated look with some a new logo, new colors, and a new search function. So I encourage you to check it out. And this is the first in a series of modifications that we're making to our website that we'll be rolling out throughout the next couple months. So look forward to that. So with that, it's my pleasure to introduce Dr. Greg Ahrens. He's going to be talking about leadership and organizational change for implementation. But to introduce Dr. Greg Ahrens, he is a clinical and organizational psychologist and professor in the Department of Psychiatry at the University of California, San Diego, and a faculty member at the UCSD-SDSU Joint Doctoral Program in Clinical Psychology. And he's also the director of the Child and Adolescent Services Research Center, or CASRIC for short. Dr. Ahrens' research has been funded by the U.S. National Institute of Mental Health, the National Institute on Drug Abuse, and also the Centers for Disease Control. His research has developed implementation conceptual frameworks like the Exploration, Preparation, Implementation, and Sustainment framework, which is highlighted on the CEBC, as well as measures of individual and organizational factors that influence implementation, like the EBPs, Evidence-Based Practices Attitude Scale, and the Implementation Climate Scale, which you can also review in detail on the CEBC. And he's also developed and tested implementation strategies like the Leadership and Organizational Change Intervention. So Dr. Ahrens' most current work focuses on improving organizational context and training managers and supervisors to become effective leaders, to create a positive implementation climate, and to successfully lead evidence-based practice implementation in their teams and organizations. And a fun fact about Dr. Ahrens is he's currently preparing to do the Boston Marathon, which we just learned about him. So with that, I'm going to go ahead and turn it over to Dr. Ahrens.
Okay, thank you, Jared. Okay, so welcome everybody. Hello, thank you for joining. And today, I'm really going to talk about leadership in general and in relation to a couple of specific projects that we have ongoing. And I just want to thank CBC for the opportunity to participate and to meet with all of you virtually today. So, slides. So, here we go. So I do need to acknowledge the support that I've had with my colleagues in developing this work over the last 15 to 18 years, including NIMH and National Institute on Drug Abuse, CDC, Fogarty International Center, where implementation science is being applied across sub-Saharan Africa and other low and middle income countries. NICHD has also been moving in this area, and a lot of the institutes within the NIH have showed an increased interest in strategies for effective implementation and sustainment of evidence-based practices. Other acknowledgements: the NIMH Implementation Research Institute that really focuses on high-quality training for early career investigators interested in implementation science, as well as the Society for Implementation Research Collaboration, and the NIH PEPFAR Implementation Science Alliance is also doing some initiatives around implementation and systemic change. All with the focus, all of these are really focused on, how do we implement effective interventions in various settings so that we get the best outcomes for those who will really benefit: the clients, patients who would benefit from evidence-based interventions. So, the question arises, why focus on leadership for implementation and sustainment? Just, to give a broad overview, it's unfortunate, but a review of home-based mental health treatment found a 55% failure rate for implemented home-based treatments. And this next piece, I think, is really critical. It's like, for programs still identifiable, many key elements were no longer a part of services. So, for those that, are implemented and sustained, we still don't know how effective they are in the long run. And so I think one of the goals to focus on is, identifying what are the core key elements, what's adaptable, what's not adaptable as we implement, so that we are implementing interventions that have a chance of really helping those in need. Recent review of dissemination implementation research in child and adolescent mental health found that only 10% of the articles were considering kind of the long-term sustainment of evidence-based interventions. And I think this is important because the more I do this work, these phrases keep coming to mind that we should first begin with sustainment in mind. If we're going to go to the trouble of and the cost of implementing, we need to really be thinking for the long run how these are going to be sustained in a way that interventions will retain effectiveness. So, in that review, some of the things related to sustainment were the issues of ongoing supervision and support, and the fit of practices in the broad context of systems, organizations, providers, and clients. And then having supportive organizational context was also important. But for all of these initiatives, and one of the reasons that I and my colleagues are focusing on leadership, is that we need to understand how leaders set the stage. So at all levels, both systemically and within organizations, at the larger system level, leaders can affect policy, funding, and how those initiatives are rolled out. And within organizations, what we call the inner context, the focus is on how leaders affect, organizational climate, resources, messaging to their staff, how they really set the stage and set the example for effective implementation of evidence-based practices. Jared, in his introduction, talked about the EBPs framework, and in collaboration with CEBC, we've been applying this to social care, to child welfare services, and mental health. But what you see on the slide before you is based on a systematic review led by Doug Novins, University of Colorado, where we reviewed all of the published literature on implementation and dissemination in child and adolescent mental health. And this is looking across the 4 phases of the EBPs framework. And in our work, we found having these phases is helpful in how we think about the implementation process. And this has been particularly useful in different research and implementation projects. And one in particular I'll highlight is the JJ Trials, which is funded by NIDA, which is funds 6 centers and a coordinating center to implement interventions for youth that are involved in both correction systems and juvenile justice, as well as community-based organizations. And it helps in thinking about moving through the stages in kind of exploring what the issues are for systems and organizations, then preparing to implement as a process, the actual implementation. And this is where I like to say you need a real problem-solving orientation as you think about implementation, because once you start implementing all the preparation that we've done, we find out where there are gaps, where we need to really address emergent issues. And then in sustainment, it's really what in the outer context of the service systems can support ongoing use of evidence-based interventions, and what in the inner context of organizations can really support the use of evidence-based interventions within organizations serving children and families. So, within this framework, you see the phases, but you also see the outer context and inner context issues that arise. And, within all of these, we see this issue of leadership and organizational context is fairly consistent across the more active portions of the EBPs framework. And so this is something that we find emergent in the literature and in our work, and in just talking with both system leaders and organization leaders in some of the challenges in implementing evidence-based interventions. This rather complicated slide I'm not going to spend a lot of time on, but this is a few features of the EBPs framework that I think are critical. One is, again, what's happening in the outer context, the service environment that's going to, on the left side, the outer context that's going to set the stage for implementation and sustainment, and how do leaders at that outer context level both set the stage and support ongoing use of evidence-based practices, both ideologically and practically speaking, right? So ideologically, are they espousing, are they talking about the importance of evidence-based practice and how it may be critical for the service system? From a practical level, are they supporting, organizations in the delivery of those services? When we look at the inner context, it's, again, intra-organizational characteristics on the right side of that slide, thinking about leadership in those organizations, specifically implementation leadership, and how organizations set policies, structure their information systems, data monitoring and feedback for fidelity, for example, and how they support the individual adopters who are their clinicians, case managers, caseworkers, and support them in developing positive attitudes and perspectives on the use of evidence-based practice. And then in the center, this idea of interconnections and linkages, those collaborations and relationships are critical. And then right below that, there's the 4 triangles that really talk about the fit of a specific evidence-based practice at the system, organization, provider, and patient. And those are critical considerations when you're thinking about how something is going to be implemented and sustained, because if there's a mismatch or a misfit at any of those levels, then it can make it a little more difficult, and sometimes a lot more difficult to implement. And then in terms of outcomes that we look at for implementation and sustainment, we want to know about continued use of evidence-based practice, the level of institutionalization in the system, how well providers are trained, how are they actually using the intervention, and are they reaching the client population, and also, has the context of systems and organizations really shifted to be supportive of evidence-based practice. So a kind of complicated slide, but the references at the bottom, and I tried to supply references for these slides so you can kind of take a deeper look at some of these things if it's of interest. So moving along now to focus more specifically on implementation and leadership. With my colleague Mark Earhart, primarily, we've been thinking a lot about how we may have leadership initiatives at system level or organization, but we really want to think about aligning initiatives and leadership messaging, leadership activities across systems and organizations in order to have the highest public health impact. When we think about leadership for implementation, we've really taken this approach of looking at this, what we call the full range leadership model, developed by Bass and Avolio, Bernie Bass and Bruce Avolio. But more recently, we've been focusing on characteristics of leaders for effective implementation, what we call implementation leadership. And I'm going to talk about each of those in turn. And then this idea of what Ed Schein at MIT is called climate or culture embedding mechanisms, go to the core of how leaders set up the organizational climate and culture for implementing any strategic initiative, creating a context that's supportive of implementing a specific strategy and evidence-based practice. And he parsed these out into what he calls primary and secondary embedding mechanisms, and I'm going to talk about that a little bit further down in the presentation. But I think it's important to draw attention to that because Ed Schein talks about this as a way for leaders to enact approaches to change the context of systems and organizations. And so that's helpful in thinking about what we as leaders can do to bring about change and really support implementation of evidence-based interventions. So we'll start by talking about transformational leadership and transactional leadership, and also what we call non-leadership or passive avoidant. These are all part of the full range model. And these are, I think the full range model is one of the most highly researched approaches to leadership and leader development. It's found to be valid across countries, cultures, service settings in industry, everything from, oil to social services to mental health. The full range model has been pretty well researched. Transformational leadership really has four components. This idea of individualized consideration, and that's a behavior where it's evident that the leader is paying attention to the individual needs and challenges for each person that's on their team or who they encounter. The idea of intellectual stimulation is another behavioral dimension where leaders can really support and garner interest among their followers in particular topic. In the case we're talking about, it's in evidence-based intervention. Being able to articulate why it might be important and how we might go about thinking about how to really support evidence-based interventions as an intellectual exercise or a problem-solving exercise, as I like to talk about. The idea of inspirational motivation, which is really about inspiring, having that vision for improving care and getting people excited about doing the work to improve care for our clients and for children and families that need help. And the idealized influence dimension is really about being a role model as a leader. So modeling how one would approach problems, modeling ethical behavior, modeling thinking about and getting excited about thinking about how to really provide the best services. Another component of the full range model is transactional leadership, and this is really about things like contingent reward, how we recognize and reinforce staff for their positive behavior, and this can be at any level of systems and organizations. At the system level, contingent reward might be how community-based organizations that deliver services are recognized for excellence in the care they give. This idea of management by exception is really attending to standards, and active management by exception means that we pay attention to any deviations and correct those. And so this is one of those dimensions where you want probably a mid-range level. Too much active management by exception is seen as micromanagement and often is not perceived well. But being able to really assess how things are going and correct things, kind of course corrections as you go, is I think in the spirit of management by exception in the active sense. And then we have what we call passive avoidant leadership, and that's really the non-engaged leader. Passive management by exception, the leader may notice problems occur but may be slow to respond or not respond at all, or laissez-faire, where the leader is just completely out of the mix and unengaged. And in the full range leadership model, we see along the dimensions of passive on the left to active on the right and less effective at the bottom to more effective at the top, that these three dimensions of the full range leadership kind of fall in this grid. So in our leader development work, we use both transactional and transformational leadership and try to avoid the passive avoidant as much as possible. But as I mentioned earlier, we're also thinking about implementation-focused leadership. And my colleague, Dr. Mark Earhart, led an NIH grant that we just recently finished up, in which we were developing measures of implementation leadership, implementation climate, and implementation citizenship behavior. The latter being kind of what employees do to go above and beyond in supporting implementing a new practice. But implementation leadership is comprised of four dimensions. The leader being knowledgeable about the practice. So for example, can they answer questions of staff about specific practice being implemented? Are they being supportive of their staff in implementation of the evidence-based practice? Being proactive in problem solving? And being perseverant through the implementation process, through the ups and downs of the implementation process, because there inevitably are ups and downs and things that need to be sorted during the implementation process. So as part of this work, we developed the implementation leadership scale, and one of the tools posted along with the presentation is the article describing the development. In our work around measure development, we're trying to be brief and pragmatic, meaning that brief, this implementation leadership scale has four dimensions: proactive, knowledgeable, supportive, and perseverant, but it's only 12 questions long, so it can be completed in a matter of just a minute or two in most cases. And pragmatic being that it can be useful. And to that end, with all of the measures that we're working on, since those were developed with NIH support, we make those freely available. So those are published along with the articles on the Implementation Science Journal website, where you can find them. But again, what we're trying to do is develop these measures for new and emerging issues in implementation where we don't have really good measures yet, but do it in a way that is will really make it easier to assess these things and come in and then address any deficits, any weaknesses, capitalize on strengths, and that sort of thing. So again, brief, pragmatic, psychometrically strong is what we're aiming for with these measures. So this next slide is just an example of the self-rating form that we've used with leader self-assessment in trainings, more broad trainings. And you can see what the questions are on the implementation leadership scale. And note in the questions, in the proactive score, for example, question number 1, I have developed a plan to facilitate implementation of evidence-based practice. We really have found these to be most useful where we tailor the measure to the specific practice being implemented. So for example, if you're implementing motivational interviewing, it'd be I have developed a plan to facilitate implementation of motivational interviewing. Or question number 4, I'm knowledgeable about motivational interviewing. And we're looking at the psychometrics, but preliminarily the psychometrics look as good or even stronger than the original when we really focus in on the practice that's being implemented. So, we're kind of beginning down this road of looking at specific implementation leadership along with full range leadership. And so the question arises, does implementation leadership matter? What's it related to? And so, one of the ways we wanted to get at this was looking at whether supervisors and the clinicians they supervise rate the supervisor's leadership the same. And it's this idea of discrepancy or perceptual distance between different people reporting on the same target, in this case, the supervisor. And what we found, you can see on the left, is that about 33%, so about a third of supervisors rate themselves significantly more positively on implementation leadership than do their staff, which is in the purple bar. About a third rate themselves essentially the same as their staff. And then on the right set of bars, you could see the supervisor rates themselves significantly lower on implementation leadership compared to how their staff rate them. So this is what we call the humble leader, and there is some literature on this idea of humble leadership. So, when we think about leadership, often we just think, does somebody score high on leadership, or does somebody score low on leadership? Are they, a strong leader, not as strong? Where do they, where could they use some development and support? But with this work on the discrepancy is telling us that it's a little more nuanced. There is that kind of mean level or average level of leadership that we can focus on. But the nuance tells us a few things, and I'm going to share with you a couple of slides that are not that intuitive to when you first look at them. But what we wanted to do was look at this idea of the discrepancy between a leader's self-report and their staff's rating of that same leader. And so we looked at this discrepancy in relation to organizational climate for involvement in the organization and initiatives in the organization. And what we found with this group is that, here we go, I got it, is that on that left upper quadrant of the response surface, this is where we had humble leaders, so the leaders that rated themselves low, the staff rated them high, that humble leadership predicts better climate for involvement in the organization. And then we also looked at this with organizational climate for performance feedback, which is important just in day-to-day management of staff, but when you think about providing fidelity feedback, it's also critical for evidence-based interventions. And so similarly to the previous slide, we also found that humble leadership, or that discrepancy where leaders rate themselves low and staff rate them high, predicted better climate or more positive climate for performance feedback. So in all, humble leaders have the best outcomes in terms of organizational climate, involvement climate, performance feedback climate. and most positive where subordinates rate the leader higher than the leader self-rated. So for us, when we think about leadership and organizational change and developing leaders, this is something that we always draw attention to as well, is what's our, for the leaders when we're coaching them and training them, what is our self-perception, of ourselves as leaders? How does that affect how effective we are with staff that we're trying to support and lead around implementing evidence-based practices? So, up to this point, I've given you kind of broad overview of the EBPs framework, talked a little bit about the full range model, gone into a little more depth around implementation leadership. And now I want to move on to a project that has some leadership outcomes where we're looking at sustainment of one evidence-based practice across 11 child welfare service systems. So this is a mixed methods examination in 2 states representing 87 counties here in the U.S. One of those states is the Oklahoma Children's Services System, and the other is 10 California counties. And again, all implementing the same evidence-based intervention. And I'll give a description of that in just a minute. But the implementations were through different funding projects in Oklahoma, through an NIMH effectiveness trial that was led by Mark Chaffin, who unfortunately passed away a couple of years ago. And in California, actually Mark was involved in our initiatives there as well. And you can see the counties highlighted in the slide, but funding came from NIMH, from the CDC, from ACF, and HRSA. And interestingly, when for one of those projects also, when there was a gap in funding, there was some help from the Office of Child Abuse Prevention in the state of California as well to help kind of get the project through a gap. So the implementations in these different counties all had slightly different paths. Some were successful, some were less successful in the implementation process, but that's why this is a good context for the study of implementation and sustainment. So the goal of the project was to really improve our understanding of how to effectively sustain following large-scale implementation. It fits in the sustainment phase of the EBPs framework, looking at both outer and inner context interactions, as well as the evidence-based practice fit across those levels that I mentioned early on. But the initial goal at all the sites was to develop local expertise to support ongoing training and coaching. So one of the, I think, really positive features about at least the initial outlook was the goal was sustainment at the beginning. And so with that as the goal, it's also a really fertile context for looking at sustainment of this one evidence-based practice. And that practice is an evidence-based intervention for child neglect called Safe Care, developed by John Lutzker and supported by the National Safe Care Training and Research Center at Georgia State University. It's an evidence-based parenting program for parents at risk of or reported for child neglect. Generally takes place with children still in the home. So it's a home-based service. It's generally provided by bachelor's level folks with various levels of experience, some very new, some more experienced. And there's a set of foundational skills and then 3 modules. And the foundational skills have to do with working with the caregivers on communication skills and on problem solving. And that runs through the more substantive modules on child health, on home safety, and on parent-child and parent-infant interaction. So for the training curriculum, there's didactic and interactive training that takes place generally over the course of a week, and trainings that involve the home visitor, coaches and a trainer, and then at least early on, there's monthly coaching for fidelity, and that coaching takes the form of in vivo observation. So the coach goes with the home visitor to the home, observes, sometimes may model behavior, may coach afterwards. So it has an approach that can really support providers in learning and practicing the intervention and developing some expertise in safe care. So in this project, there was one state-level child welfare system with 3 CBOs across 6 regions. County-level child welfare social services, there were 8 of those, 2 offering direct services by system-level employees, and then 12 contracting with CBOs providing services. There was one county-level public health system that used public health nurses and CBOs to deliver care, public health nurses kind of as the training team, and then one county-level mental health agency that contracted with a mental health community-based organization. You know, when we think about what is sustainment, then we had to come up with a definition, and fortunately for us, Shannon Wiltsey-Sturman had completed a systematic review and identified 3 levels of sustainment. Full sustainment, meeting all core fidelity requirements for an evidence-based practice, partial sustainment, meeting some of those, and non-sustainment, not utilizing the model. And looking at implementation 2 to 10 years after initial implementation, 3 sites were non-sustaining, 1 site was partially sustaining, and 7 sites were fully sustaining, at least by the criteria. And that was determined by the research team based on our knowledge of each system and working together to kind of identify the level of fidelity and rigor with which things were being implemented. So we went through a collaborative process to do that. So the survey participants were 45 administrators and 212 home visitors. And for system level leadership, we used the program sustainability index of the a larger institutionalization program. It's the PSI items are around leader competence, and you can see what those items are. Did the leader establish a project's mission and vision, engage in early planning for sustainment, continue planning for sustainment, develop and follow a realistic project plan, and identify alternative strategies for project survival. These are very similar to the dimensions of the implementation leadership scale in terms of being proactive, perseverant, and coming up with strategies to implement and sustain. So what we found was that where we had more positive leadership competence, there was significant difference between non-sustaining and full and partial sustaining sites. So leadership at the system level predicted, and this was true kind of prospective data where leadership assessed earlier predicted sustainment down the road. When we looked at the inner context team leadership, these are the direct service staff rating the leadership of their team leader. We looked at the full range leadership data and found that for transformation leadership, those sites higher on transformation leadership had a significantly higher probability of sustaining compared to non-sustaining sites. We didn't find any significant effects for transactional leadership, but for passive avoidant leadership, we found a pretty striking effect where there was passive avoidant leadership. The likelihood of not sustaining was significantly and much higher. So, looking across all these service systems, leadership matters at the system and at the organizational level. So we also did some qualitative work, and I'm going to go very briefly through the qualitative work. But there were 44 interviews with state, county, and CBO administrators, and 14 home visitor focus groups with almost 100 home visitors to look at issues around leaders. And some of the questions are, how are leaders within your state or county or agency influencing the ongoing use of safe care, and who are the most important decision makers, and why are they important? And at the agency or intercontext level of the CBOs, how have leaders within your team supported use of safe care? What have they done to support or undermine the use of safe care? And who are the most important decision makers? Again, why are they important as well? So just quickly, in non-sustaining sites, what we found, again, 3 of the 11 sites failed to sustain. But leadership issues were things like change in upper level leadership during the preparation phase. So early in the process of implementation, when there are changes in leadership, that can really affect the sort of the trajectory of the implementation process. So either change in leadership or lack of a clear upper level leader who shows strong support. So in non-sustaining sites where safe care was perceived as too rigid or wasn't high on a priority list, that was related to non-sustainment. And then lack of knowledge of evidence-based practice in general and safe care in particular. This relates to that ILS implementation leadership scale, knowledgeable leadership. One CBO director stated that a lack of knowledge among system leadership resulted in the evidence-based practice being of low value in a priority list. And then some, also that can be related to safe care or an evidence-based practice not being given the time or dedication needed. So lack of strong team leadership as well at the organization level was seen as related to sustainment. And so leader factors supporting sustainment were, when we think back to that really complicated EPIS framework with the network and linkages between systems, the linkages between outer context and inner context of CBOs. So what were the relationships, communications, and working process between outer context leaders and inner context CBOs? Were they there? Were they being utilized? Was there some back and forth process that supported implementation? Those were important in sustainment. Also, effective team leaders would have a strong understanding of the evidence-based practice, knowledgeable leadership, facilitate ongoing meetings and support, being proactive, ensuring that providers have what they need, so being supportive, and communicating needs to higher ups in the organization. So if that was need for more training or if it was need for materials to support families, so for example, do they have, can they provide locks for cupboards so that you can create a safer home environment? It can be things as simple as that to other needs like having the right people on their team, but that proactive leadership and upward influence in the organization is also important.
Okay, so it looks like we have our first poll question. So we're going to open up a pod on your screen, and the question is, the 2016 Nobel Prize for Economic Sciences, the winner won for their work on A, macroeconomics, B, microeconomics, C, contracting, D, finance. Go ahead and make your selection. All right, looks like folks are done voting, so we're going to go ahead and broadcast the results. I'm having a hard time viewing that. That's too tiny. Make it bigger. So it looks like the number one is macroeconomics.
So how do we go on?
All right. So Molly will close the poll.
Okay. So here's the big reveal and of interest to those of us in public sector. So Hart and Holmstrom won the Nobel Prize in Economics for their work on contracts. And the reason that I really like to raise this, because the lowly contract is something we think, the contracting process is maybe a necessary evil or something that has to be done. But I think in a lot of service systems, not just child welfare, but in alcohol and drug, in behavioral health, community systems and public systems, this idea of contracting and procurement processes, it bridges that outer system context in the inner context. It can support or limit a given evidence-based practice. So when we think about what goes into a contract, a good contract, I think Hart and Holmstrom might argue would really specify what the expectations are in that relationship between a system and contracting CBOs, for example. So statements of work can specify what's required, what's expected. And in the language of implementation climate, coming back from Catherine Klein at Wharton Business School, the idea of how does a system say what's expected, supported, and rewarded. So contracts can really have that. It can signal or communicate the implementation climate at the system level. Again, what's expected, supported, and rewarded. And how does this relate to leadership? Well, leaders set the stage for what's institutionalized and how. So what goes into that contracting process? So that becomes really critical in thinking about how we bring evidence-based practice and how leaders at a system level can work with leaders in organizations. And hopefully leaders in organizations are working with what we call their first level leaders, their team leaders, their program managers and leaders in developing this positive implementation climate at the system and organizational level. Yeah. And okay, so I think in the interest of time, I'm going to skip a couple of slides here really quickly. And we're going to go to some other quick poll questions.
Okay, so this is an easy one. Have you ever had formal leadership training, yes or no? All right, looks like most of you have said yes, you have.
Only by a small margin.
By a small margin.
Okay. Okay. And then we had one other. Okay.
It's a follow-up question, and is if you have had formal leadership training, how much of the training content do you remember and apply as a regular basis? So the responses are none, a little, some, or a lot.
I think some is going to win out here.
Yeah, so we can go ahead and close that one. Looks like the majority says some.
Yeah. Okay, so this has implications for what I'm going to talk about in the last 10 minutes here. And that's our work on leadership and organizational change for implementation. And we've had two NIH studies. One was a pilot study from NIMH where we developed and tested a strategy, a leadership strategy, what we call LOSI, mental health programs. And then our current project, which is a much larger scale, funded by NIDA, where we're testing LOSI compared to a webinar training in 60 substance abuse treatment programs. And the reason I asked both about leadership training and for those who have had training, how much they actually utilized it is because what we've seen in our work and anecdotally is that folks go to leadership trainings, they get really excited about it and come back, and then that manual or whatever materials go on a shelf, and some of it may be utilized but not so much. So the LOSI, we'll talk about the components, but really has a focus on some didactic and interactive training, but then ongoing, very brief, like 10 to 15-minute coaching calls per week. In our pilot study, supported by NIMH, in terms of feasibility in agencies, our participants in the loci condition compared to the webinar leadership trainings had higher engagement, increased leadership knowledge, applied what was learned. This is their self-report again, so keep that in mind that that's not staff report. Applied what was learned, improved their own leadership behaviors, felt that they improved their ability to manage change, changed their behavioral routines and leader behaviors, and increased emphasis on evidence-based practice. So that's kind of supportive. And then they had a higher perceived overall utility of kind of the in-person and coaching approach compared to those that did the webinar training. So, we also saw staff-reported changes in supportive leadership behaviors. So you can see here the green line is the loci condition, the red line is the webinar, and after about 3 months, staff started to recognize and see some changes in their leader. But based on this, what we've done is expanded the loci leadership intervention to be a year-long to help really create and improve leadership and create a context for implementation climate that'll support evidence-based practice. And so, the intervention loci itself has the leader development activities of didactic training, the ongoing brief coaching, and then collaboration among the teams. Implementation climate development activities and linking organizational and multi-level leader buy-in strategy with leader development, and that's what we call our AWESOMs, or our organizational strategy meetings, where we're working with the organizations to support what we call first-level leaders. And the first-level leaders are the program managers, the clinical supervisors who are supervising the staff who are directly delivering services. And our approach is that, the first level is important, but really other levels in the organization really have to support leaders in their efforts to implement and sustain the evidence-based practice. So the loci intervention, again, there's the loci leader training plus coaching plus org strategy compared with the leader, or compared with webinar training alone, and considering the leader development activities in conjunction with implementation climate development activities, and then linking that organizational strategy and multi-level leader buy-in with the leader development. So strategic alignment across levels. And so, I think some implementation efforts follow this idea, the arrow that just appeared, where things are going in different directions between executive supervisors and counselors. And what we want to see is, this on target, we're all moving in the same direction through effective leadership to implement new practices. So I mentioned early on this idea of embedding mechanisms from Ed Schein at MIT, and we focus mostly on what Ed Schein calls these primary climate embedding mechanisms. So what leaders pay attention to, measure, and control, how they react to critical incidents. So if a crisis occurs around implementing a new practice and the leader doesn't react, does that signal a laissez-faire attitude or sort of a passive attitude? So that's where that reaction to critical incidents comes in, how leaders allocate resources, role modeling, teaching and coaching, rewards and status, which can be just recognition in the agency, and how leaders recruit, select, and promote. And so some of the things that are happening in some of our organizational strategy is, we're thinking about how the use of evidence-based practice can be built into performance assessment, how recognition for excellence in evidence-based practice can be supported and recognized organization-wide. So there are a number of examples of that I think can be really useful. Secondary embedding mechanisms are more macro, so rites and rituals of the organization, design of physical space, stories about important events and people. but also formal statements of organizational philosophy and creed. And one of the agencies that we worked with in the IMH study, had their in their mission statement was the importance of using evidence-based practice for the benefit of their clients. And so that was a company value, one of those secondary embedding mechanisms. So in brief, the LOSI leadership program has these dimensions. It has the didactic leadership training, which is a 2-day in-person training where we go over full range leadership, implementation leadership, organizational climate, implementation climate, and we use data down below from these data-driven 360-degree assessments in those trainings. So the leadership training that we're testing is very data-driven in terms of helping develop individual development plans for each leader based on a 360-degree assessment where the staff rates the leader rate themselves, and then someone higher up in the organization also rates that leader. For the leadership coaching, it's weekly one-on-one coaching calls with the LOSI trainer, and then monthly group collaborative calls. And again, the one-on-one coaching is really a check-in to keep leaders thinking about their goals, problem solve any things that have come up in the previous week, but to move on quickly. So we want it to be low burden. The data-driven assessments are web-based surveys assessing climate and leadership throughout the course of the study, baseline 4 months, 8 months, 12 months, and then 16 months after the fact. And then the organizational strategy meetings we do in person with monthly calls with agency executive directors and middle management to really look at data and think about the implementation process. So this, in a nutshell, is kind of what we're doing with LOSI, and you can see the reference on the bottom here. And we could also make that available, I think, after the talk, the study protocol for that project. But just to sum it up, I like to think, we have to be kind of committed to implementing and sustaining to help our leaders make the changes that they want to make. This hat, I think, sums it up, that was given to me by my research staff. Don't complain, just sustain. Let's get in there and do it. So I think we have maybe just a couple of minutes for questions.
So we did get some questions for Dr. Ahrens. The first one going back to the EPIS model. Someone asked, can this model be applied to organizational quality improvement efforts that aren't necessarily evidence-based?
Yeah, I mean, the principles that we take are based on the literature of kind of change management and innovation implementation. So, what I think is important is to have whatever you're implementing be as well circumscribed and as well put together as possible, so you know what you're implementing, right? And that's where, evidence-based interventions, some more than others, however, tend to have good documentation. This is what the practice is. These are what the expectations are. This is how we know if we're delivering it with fidelity.
Great. And then another question going back to when you were talking about the qualitative study on factors in sustaining sites. The participant asks, some of these leadership challenges relate to the stages of organizational change, i.e. need a strong leader as a champion. Did you look at this in the study?
Yes, I mean, we didn't put it in terms of the literature on stages of change, stages of organizational change, which really comes out of the stages of change literature in individual change. But yeah, we think of this in those terms as well, and how do you move an organization through the implementation process. And so we're thinking of those stages in terms of like the EPIS framework. When we're exploring what's to be implemented, what's the context for implementation, that leads us into that next phase of how do we prepare, right, to implement and go through that into actual implementation where that strong problem-solving orientation is needed, and then on to sustainment. Great.
All right, so with that, it doesn't look like we have any further questions, so we're going to go ahead and wrap up. You can see on your screen Dr. Ahrens' contact information if you have any questions, or if you have any questions about the CEBC, just feel free to log onto the website and hit the contact us button and send us an email. So with that, we're going to go ahead and call it a day.
Thanks, everyone.
Thank you.
Thank you.